We've had so many questions come to us about Medicare Part D, looking at increased premiums, and then also the IRA with their approach to the premium tax credit. And we're hearing about this from providers. We've got questions that are coming from seniors because they've seen their choices diminish and their premiums increase. And to them, that's backward. They want more choices and more options. So, Mr. Merkel, the taxpayer cost associated with both the Part D premium stabilization efforts and the expansion of the PTC, how do you see these policies affecting that long-term affordability, that long-term access that seniors are now beginning to question?
Yeah, thank you very much for the question. I think both of them are sort of part of a disturbing trend, which is we don't like the underlying value of the product. For ACA, it's narrow networks, it's high cost sharing, it's high premiums. And for Part D, it's a premium spike and plan choices dwindling. And the immediate response is just to throw more taxpayer money at it. And unfortunately, that's not a long-term solution, and it's quite expensive for the taxpayer.
Ms. Axelson, I'd like to come to you because the IRA's price controls are problematic, and there are 21 drugs and 36 research programs that have been halted due to the IRA. And what we are seeing from some of the forecast in the future is suggesting 188 fewer small molecule treatments in the next 20 years. So what action should we take to ensure that we continue with innovation?
If we feel that federal price controls are necessary, they should not be implemented until 13 years at a minimum after the drug is approved. This differentiation between small and large molecules is based in no evidence, and it discourages the most efficient type of drug development that is necessary.
And what about biosimilars?
Oh, biosimilars.
Go ahead and talk with that, too.
Oh, okay.
No, I want you to talk about small molecule, but the biosimilars also.
By pushing the prices of a drug down towards the end of the life cycle with a price control, the government is discouraging the launch of biosimilars and generics. Biosimilars and generics enter a market because they make money right when the drug is going off patent because of the price difference between the brand and the generic. Same thing with biosimilars. The biosimilars market is in development. By putting in a price control, the federal government is discouraging the most cost-effective mechanism we have in healthcare, which is the entry of generic and biosimilars.
And, you know, this is something that we are looking at in the committee. We have some PBM reforms that we've already advanced out of committee. And we know that these changes would increase the biosimilar uptake and would lower cost for patients. So when we look at these price controls, when we look at the IRA's impact, when you take into consideration these small molecule drugs are vital for treating things like Alzheimer's and some cancers that are there. We know that the IRA's accelerated price setting is something that would dampen access, would hamper access to that market, and we're quite concerned about that.